Hi there, in this video we are going to discuss different characteristics of the benign and malignant neoplasm. So basic three properties which differentiate benign and malignant neoplasm are differentiation and anaplasia, local invasion and metastasis. So we are going to discuss them one by one. So first of all we move toward differentiation and anaplasia. What does differentiation mean? Differentiation means that a cell is committed to perform specific function. For example, cartilage performs the supportive function inside the body, and it is made up of chondrocytes. So chondrocytes are the differentiated cells which are destined to perform the function of support. At the very same time, a bone is composed of osteocytes, and osteocytes are also differentiated cells which are destined to perform the function of support inside the body and formulate the bone. So osteocytes are the differentiated cells, and these arise from osteoblast. Chondrocytes are the differentiated cell which come from chondroblast. So this is the concept of differentiation. So what is anaplasia? Anaplasia means lack of differentiation. So it is literal meaning of anaplasia or backward formation. So anaplasia is also regarded as de-differentiation. De-differentiation. It means that a cell was differentiated and later on it led to the undifferentiation or de-differentiation. This is called anaplastic change, and the tumors which lack differentiation are called anaplastic tumors. So what does it mean that a tumor is anaplastic? It means that tumor cells are not differentiated and not committed to perform the specific function. A well-differentiated tumor is a tumor in which cell resembles to the original original cells, or the cells from which tumor arise. For example, a chondroma. For example, we take an example of chondroma. Chondroma is the benign tumor of cartilage. So in the chondroma, cell will resemble to the chondrocytes or the cartilage forming cells, and in lipoma, cell will resemble to the lipid cells or adipocytes. Okay, so these are the examples of the differentiated tumors. However, in undifferentiated or anaplastic tumors, cells don't resemble to their original cells, and there is more. When there is more anaplasia, there is more malignant potential. Well differentiated tumors are mostly benign tumors, or you can say otherwise, benign tumors are mostly well differentiated tumors. However, the malignant tumors are malignant tumors can be differentiated and can be anaplastic. Anaplasia is the characteristic of malignant tumors. You can say a well differentiated tumor can be benign as well as malignant. However, an anaplastic tumor is always malignant. Okay. So what are the different characteristics which an anaplastic cell shows, or anaplastic tumor shows? It shows pleomorphism. What does it mean? Pleomorphism means different cells have different size and shape. For example, supposedly we have a well differentiated tumor. In well differentiated tumor, all cells will be of equal size and same shape. However, when there is pleomorphism, this shape will change into kind of irregular cells. Okay, some cells will be large, some will be small, and so on. This is called pleomorphism. Cells have different size, different shape. Then cell will have nuclear abnormalities. What does it mean? It means that their nuclei will be showing increased size. Okay, size of nucleus will increase, and the nucleus will almost fill the cytoplasm. So this property is called increased nucleus to cytoplasm ratio. It means that nucleus will be increasing in size, and it will fill most of the portion of cytoplasm. So there will be abundant mitotic figures. It means that rate of mitosis will increase, and we know that in normal mitosis, cell arrange at the chromosome arrange at the two poles of the cell at the end of anaphase, and then these two cells divide. However, in this cell, instead of these two poles, there can be three pole, in which chromosome may move to three poles. Okay, or there can be four poles, and so on. So these are the different nuclear abnormalities which anaplastic tumors show, and there increased nuclear to cytoplasm ratio. There are abundant mitotic figures, or abnormal mitotic figures, and there are you can say abundant nucleoli, and so on. And these tumor can also lead to the formation of giant cell. Giant cell are basically in large cell, you can say a cell like this is a giant cell, multinucleated giant cells. Okay, and they show atypical mitosis, and there is loss of polarity. Loss of polarity means they become oblivious of each other and don't show up regular growth pattern. Instead they grow randomly. For example, if a tumor arose from a gland like structure and these tumors lost their polarity, and instead of forming gland they begin to grow in the form of sheets and so on. So this is basically pleomorphism, which the malignant tumor show the correct. Next we move on towards dysplasia. What is dysplasia? Dysplasia is basically disordered proliferation of the cells. It means that the normal proliferative pattern or the growth pattern of the cell is damaged, and this dysplastic cell or dysplastic tissue also shows pleomorphism, which is different in size and shape of the cells, and abnormal nucleus, increased nuclear to cytoplasm ratio, and abnormal location of mitosis. What does it mean? Supposedly we take an example of stratified squamous epithelium. What happens in stratified squamous epithelium? Basal layer are basically cuboidal, low columnar, you can say, and these cells then they move on above. These cells are gradually replaced by squamous cells. Then these squamous cells also lose their nuclei, and top layers are basically keratin layer. So in this way, there is stratified squamous epithelium. So what happens in dysplasia? In this normal epithelium, the cell division is limited to the basal layer. Okay, cell divide at basal layer, and these new cell formed move aboveward in upper layers. However, in dysplastic change, what happens? This cell division is disrupted, and cell begin to divide in the all layers of cell. Supposedly here also cells are dividing, here also cells are dividing, and the cells are also showing pleomorphism. Size is disrupted, normal growth pattern disrupted, and this is a dysplastic epithelium. Okay, so this is basically dysplasia, which is disordered proliferation of the cells. And when these dysplastic changes cover entire thickness of the epithelium, when they cover entire thickness of epithelium, it is termed as carcinoma in situ. What does it mean? It means that this carcinoma is limited to the tissue, and it has not invaded from the invaded through the basement membrane. This is basement membrane. So as long as carcinoma has not invaded the basement membrane, it is called in situ carcinoma in situ. However, if these cells cross this basement membrane and spread downward away from the basement membrane, then it is invasive carcinoma. It is not carcinoma in situ in that case. And as long as these dysplastic changes are limited to some portion of epithelium, not the entire thickness of epithelium, they can revert back, as we will study in the cervical carcinoma. However, when they become carcinoma in situ and cross the basement membrane, they move toward aggressive course. Okay, so this was the basically differentiation, anaplasia and dysplasia. Now we move toward the next characteristic difference between benign and malignant tumors, which is local invasion. So what happens? Benign tumors are basically slow growth tumors. They are well differentiated, and when they are growing slowly, this is positive tumor mass, and it is slowly growing, increasing in size. It exerts pressure on the surrounding tissues, and these surrounding tissues become hypoxic. When they become hypoxic, fibroblasts accumulate here and form a capsule-like structure. So these benign tumors become encapsulated, and they become encapsulated. The result, they are well movable and freely movable tumors. Well encapsulated, well differentiated, movable tumors. However, it is not always true. Some tumors are not encapsulated, but they are also benign. For example, hemangioma. This is a non-encapsulated benign tumor. However, a leiomyoma of uterus, it is a encapsulated benign tumor. Okay. However, the malignant tumors are mostly non-encapsulated. Even if a malignant tumor appears to be encapsulated, it can be a deception. It can be a deception. How? Because supposedly this was a malignant tumor, and you imagine that this is a tumor, and this is a tumor here, and this bluish color appearing, suppose that this was a capsule. But in malignant tumor, what happens? In most of the cases, small crab-like extensions are going out of the capsule, and these extensions are basically showing local invasion. So in case of malignant tumor, it is always necessary when you surgically excise the tumor, you should examine the margin of the excised tissue microscopically to imagine to observe these crab-like extension. If there are extension, then more tissue should be excised to until the surgical margin are clear of the or clean of the these crab-like extensions. So it is the local invasion. Local invasion is also basically a property of malignant tumors, not of benign tumors. And next one is the metastatic spread or metastasis. So metastasis is basically characteristic of the malignant tumors. Benign tumors don't show metastasis, and the potential of a tumor to metastasize is directly proportional to its degree of anaplasia and tumor size. Greater degree of anaplasia, greater metastatic potential. Greater tumor size, greater metastatic potential. Okay, and some malignant tumor, however, don't show metastasis. However, they spread locally. For example, basal cell carcinoma of skin, CNS tumors. It is either locally destructive, locally expand and destroy local tissue, but don't show metastasis. Now we come toward principal route of metastasis. How metastasis occurs? Metastasis basically occurs through different three main routes. One is seeding of the body cavities, other one is lymphatic spread, and the third one is hematogenous or spread through blood. So seeding of body cavities occur in case of mostly ovarian carcinoma or ovarian cancer, which seed the peritoneal cavity, and the seeding of body cavity is also occur in case of medulloblastoma, which is CNS tumor, and ependymoma, which spread to the ventricles of the brain, and they can also show drop metastasis. And you will study these tumors next one in the respective chapters or respective systems. And next we move toward lymphatic spread, and lymphatic spread is mostly shown by carcinomas, and carcinoma is basically epithelial tumors, and the hematogenous spread is mostly shown by sarcomas, which are mesenchymal in origin. So it is not a you can say hard and fast rule. Carcinomas can also spread by blood, and sarcomas can also show lymphatic spread. Okay. So in carcinoma, we should be knowing two terminologies. One is sentinel lymph node. What is sentinel lymph node, and what is skip metastasis? Sentinel lymph node is basically first lymph node draining the tissues. Okay. Supposedly in breast cancer, breast carcinoma mostly occurs in the upper outer quadrant of the breast, and it mostly goes into axillary lymph node, and first axillary lymph node which comes into the pathway and cancer cell gets settled there. It is called sentinel lymph node. And what is skip metastasis? Skip metastasis means sometime cancer cells, instead of settling into the first lymph node, skip it and move to the second one or subsequent lymph node. This mode of metastasis is called skip metastasis, and you can observe both kind of metastasis in case of malignant tumors. And these lymphatic spread mostly occurs to the region where lymph nodes, region of the lymphatic drainage of particular tissue. And it is not always true that the lymph node draining a particle site of cancer are always be increased in size due to metastasis. Sometimes they may be increased as a result of inflammatory reaction going on there due to cancer antigen coming from or cancer debris coming into the lymph nodes. And sarcomas mostly spread into the blood vessels and by blood, and this mode is commonly seen into the different body tissue tumors we will study on individually in the different systems. However, we discuss the principal site of their settlement. They mostly settle into the liver and lungs. For example, the sarcomas which are get drained into the cable blood vessels, which mostly portal veins mostly which goes into the liver, and the sarcomas which come into the cable blood vessel, they go into the heart, and from heart they move to the lungs. So they basically settle into the first capillary bed they encounter, which is mostly liver or lungs. Okay, so supposedly a sarcoma came from a carcinoma, cancer or tumor originating from the GIT tract, get involved into the blood vessels of the GIT, which drained into the liver, and its carcinoma metastatic tumors or cell get settled into the liver. And the very same way a cancer got invaded the vena cava, and it goes into the heart, and from heart it gets settled into the lungs, where encoding the first capillary bed. Okay, so these are the different site of settlement. However, it is not always hard and fast rules about the carcinoma cancer. Don't follow the rules, sadly, and they can show a deviation from all the rules set by human beings. Okay, so it was all about today's lecture. Thank you.